Welcome to the Deep Dive, where we unpack complex topics to give you the most important insights fast.
Hey there.
Today, we're diving into something that impacts so many lives, often quietly, the intricate world of substance use.
It really does.
Yeah.
And while many substances are just, part of our daily routine,
Exactly. Understanding their true effects and where responsible use ends and, well, problematic use begins, it's incredibly nuanced, isn't it?
it really is. It's a space filled with evolving science, shifting definitions, and just profound human impact.
So our mission for this deep dive is to pull back the curtain on alcohol use disorder and other substance use disorders.
Yep. We'll explore what really defines problematic use, its far-reaching health impacts, and crucially, the evidence-based strategies for prevention, early identification, and effective treatment.
And we're building this understanding from a solid foundation. Our insights today are drawn from comprehensive medical curricula, the most recent national surveys, and the latest clinical guidelines.
Right. And given the widespread impact, our primary focus in this deep dive will be on alcohol and prescription opioids, but we'll definitely touch on other substances too.
Okay, let's jump right in. Starting with something basic but maybe not so simple. What is a drink?
Huh. Yeah, it's surprising, right? We use the term all the time.
So our sources tell us a standard drink contains about half a fluid ounce or 12 grams of pure alcohol.
That's the key, the pure alcohol content. So that translates to roughly, 12 ounces of regular beer
Or 8 to 9 ounces of malt liquor, 5 ounces of table wine.
or a 1.5-ounce shot of 80 proof spirits. The main takeaway isn't just the measurements, it's that the amount of pure alcohol is the standard unit, not the glass size.
And what's truly fascinating here is how that standard drink impacts different individuals so uniquely. It's really not one size fits all.
Not at all. Your weight, for example, matters generally. Higher body weight, less intense impact.
Gender, too, you mentioned. Women are affected more significantly.
They tend to be, yeah. Then you get genetics, how fast you drink, whether you've eaten, even your built-up tolerance.
Yeah, so many variables. Predicting a specific effect on someone sounds incredibly complex.
It is pretty tricky, which leads us straight to blood alcohol levels, or BAC.
Right, usually reported in grams per 100 grams of blood or milligrams per deciliter.
And the general rule of thumb, based on our sources, is that 2 standard drinks can bump an average person's BAC by about 50 milligrams per deciliter, or 0.05%.
Okay, so knowing those numbers helps us understand impairment better.
Exactly. For someone not dependent on alcohol, under 25 milli-GDL, maybe just feeling warm, a bit talkative.
But then 2550 milli-GDL
That's when you start seeing euphoria, some clumsiness, minor judgment issues,
and 5100.
impaired senses, slowed reaction time, decreased reflexes. That's starting to get noticeable.
And then the big jump,
Yeah.
100, 250 milli-GDL.
Yeah, that's where you get significant coordination problems, unsteadiness, slurred speech, confusion, and crucially, 0.08% or 80 milli-GDL that's legally intoxicated everywhere in the U.S.
Wow, and beyond 300 milli-GDL.
Serious risk of death. The median lethal concentration for non-dependent folks is around 450, though incredibly, survival at much higher levels, even 1,500, has been reported. Quite variable.
Okay, let's bring in that example, Mr. Stubbs. 50-year-old executive hits a tree after a party, said he only had 2 glasses of wine.
Right. But his BAC was 112 milli-GDL.
That doesn't add up, does it?
Not at all. A 112 BAC is consistent with maybe 4 or 5 standard drinks, definitely not 2.
So legally intoxicated, for sure.
Absolutely. And more importantly, it means significant impairment in reflexes and reaction time. That explains the accident.
Which really raises that big question. How much alcohol is actually healthy?
The million-dollar question. And our understanding there is really changing.
For ages, we heard about the J-shaped curve, right? Suggesting moderate drinking was maybe better than abstaining, especially for the heart.
Yeah, but the thinking now is that those earlier studies had some problems. They were often confounded.
Meaning?
Well, the moderate drinkers might have just had other healthier habits overall, diet, exercise,
Okay, so it wasn't necessarily the alcohol causing the benefit.
Possibly not. And a more recent study, a Mendelian randomization, one from 2022, which tries to get around those confounding factors, actually found a positive link between alcohol use and cardiovascular disease, starting even at moderate levels.
So the picture is getting clearer and maybe less rosy for moderate drinking.
It seems so. Plus, our sources emphasize that even low levels of alcohol increase the risk of certain cancers.
Like breast cancer in women?
And colorectal cancer in men. So the insight now is leaning towards there's no truly healthy level just lower risk use.
That's a major shift.
It is. And beyond that, there's just no debate about the serious complications from heavy alcohol use. We're talking heart problems like arrhythmias, cardiomyopathy,
Gut issues like pancreatitis, cirrhosis.
kidney and metabolic problems, electrolyte imbalances, osteoporosis, and then the neuromuscular stuff. Wernicke's, Korsakoff's, seizures. It's basically every system.
Okay, so with that foundation, let's unpack how we actually define problematic use. Because like you said, it's not always a clear line, it's more of a spectrum.
Exactly. It goes from abstinence to light moderate use, then into heavy or hazardous drinking, and finally alcohol use disorder, or AUD.
And there's this term unhealthy alcohol use. What does that cover?
That's a really crucial category. It describes drinking patterns that are harmful, but maybe don't meet the full criteria for AUD yet.
Okay. Are there specific limits for that?
Yeah, the National Institute on Alcohol Abuse and Alcoholism, NIAAA, gives us some cutoffs. For men, more than 2 drinks daily, or 14 a week, or 4 on any single occasion.
And for women?
It's lower. More than 1 drink daily, 7 a week, or 3 per occasion.
And that's for healthy adults, right? What about older adults?
Good point. Men over 65 should generally follow the women's limits due to physiological changes.
So just to be clear, a woman having, say, 1 or 2 drinks most nights,
That would fall into unhealthy use.
or a man having 5 beers on a Saturday night.
Also unhealthy use, even if it's just once a week. They might not see it as a problem, but medically, it crosses that threshold.
Right. And this connects to how these things are diagnosed, doesn't it? There was a shift away from abuse and dependence.
Yes, a big shift with the DSM-5 back in 2013. Those terms were replaced by a single diagnosis, substance use disorder, or SUD. And it exists on a continuum mild, moderate, or severe.
Okay, let's break down the criteria for SUD. There are 11 of them.
Yep, grouped into 4 main areas. First is impaired control.
Exactly.
Things like using more or for longer than you intended, wanting to cut down but not being able to, spending a lot of time getting, using, or recovering from the substance, and having intense cravings.
Okay, that's impaired control. What's next?
Second is social impairment, failing to fulfill major roles, work, school, home, having relationship problems because of use, giving up important activities.
Makes sense. Third.
Risky use. This is things like using in situations where it's physically dangerous, like driving, or, importantly, continuing to use even when you know it's causing or worsening physical or psychological problems.
Now, that sounds like a big one. And the fourth area, this involves tolerance and withdrawal.
Exactly. Pharmacologic dependence. Developing tolerance needing more for the same effect, and experiencing withdrawal symptoms when you stop or cut back.
But there's a key point here about prescribed meds, right? Tolerance and withdrawal alone don't equal SUD.
Crucial distinction. For medications taken as prescribed, tolerance and withdrawal are often expected physiological responses. You need at least one other criterion from those first 3 groups, impaired control, social impairment, or risky use to diagnose an SUD in that context.
Got it. And severity is based on how many criteria someone meets.
Right. 2 or 3 criteria is mild SUD, 4 or 5 is moderate, and 6 or more is severe.
Going back to Mr. Stubbs hitting the tree, his continued drinking despite that accident, that seems like a clear example of risky use.
Absolutely. Continuing despite negative physical consequences, the crash is a very strong indicator for AUD. It's often that blind spot where the consequences are obvious to others, but not enough to stop the person.
Which highlights why screening and early identification are so important.
Definitely. The Youth Preventive Services Task Force found screening is useful precisely because even brief interventions can help people reduce their alcohol use before things get worse.
So what tools do clinicians use for screening?
The IUDIT is well known. That's a 10-item questionnaire. But often, the IGTC, just the first 3 questions, is used. It's almost as good for picking up heavy drinking in AUD, and it's quicker.
And you mentioned a single question that's surprisingly effective.
Yeah, it's pretty powerful. Simply asking, when was the last time you had X or more drinks in one day? Where X is 4 for women, 5 for men. A yes to that is a strong indicator of hazardous or harmful drinking.
Wow, that's efficient. So a practical approach in a clinic might be:
Ask everyone if they drink. If yes, ask about frequency and quantity. Then hit them with that X or more drinks question. If that's positive, then you start exploring the other DSM-5 criteria. How is alcohol impacting their life?
like that example of the 45-year-old teacher having 6 beers on weekends. For a man, 6 is more than 5, so that's a positive screen.
Exactly. It flags a pattern that needs a closer look. It's not about where he drinks or what type. It's exceeding those quantity limits defined as unhealthy.
And if screening flags unhealthy use, counseling can really help.
Amazingly so. Our sources show that brief counseling, we're talking maybe 5 or 10 minutes, is effective at reducing consumption, and the positive effects can last for years. Up to 4 years, some studies show.
And it doesn't have to be a specialist doing it.
That's another key point. Primary care docs, nurses, other health professionals can deliver this effectively. It really broadens the reach.
So what does this brief counseling involve? I've heard of the 5 A's.
Yeah, the 5 A's are a great framework. First, assess drinking using a screen. Then, advise on sensible limits and risks. Agree on goals with the patient, maybe cutting back, maybe stopping. Assist them with skills, motivation, support. And finally, arrange follow-up or referral if needed.
So the vibe is empathetic, non-judgmental.
Absolutely, and clear about concerns and recommendations. For unhealthy drinking, the goal might just be reducing consumption, not necessarily immediate abstinence.
But that's different for someone with moderate to severe AUD, right? Brief advice isn't enough then.
Correct. For moderate to severe AUD, you're looking at needing ongoing, more extended counseling and potentially more intensive treatments.
Okay, let's shift to something more intense. Alcohol withdrawal. That can be really dangerous.
It definitely can be. Alcohol withdrawal syndrome usually shows up in 3 clusters. First, autonomic hyperactivity.
Meaning?
Shakes, sweating, fast heart rate, anxiety, feeling agitated. That can start within hours of the last drink, peaks around 24-48 hours.
Okay, cluster 2.
Neuronal excitation. That's where seizures can happen, typically 12 to 48 hours after stopping.
And the third, the one people often hear about DTs.
Delirium tremens. That involves serious confusion, altered consciousness, vivid hallucinations, seeing, feeling, or hearing things that aren't there, plus really severe autonomic hyperactivity.
When do DTs usually show up?
Typically 48 to 72 hours after the last drink. They're actually rare, less than 5% of cases, but they are a medical emergency. They can be fatal if not treated.
So, deciding whether to treat someone outpatient versus inpatient for withdrawal, what guides that decision?
Several things point towards needing inpatient care. Moderate to severe withdrawal symptoms already, a history of seizures or DTs if they can't cooperate with follow-up, other serious medical or mental health issues if they can't take oral meds or if they failed outpatient detox before.
And the go-to treatment for withdrawal itself?
Benzodiazepines. They're the standard of care, safe and effective. Meds like diazepam, chlordiazepoxide, lorazepam, oxazepam.
Any preference among those?
Often longer-acting ones like diazepam or chlordiazepoxide are preferred because you can dose less frequently. But lorazepam might be better if someone has severe liver disease.
How are they dosed? Fixed schedule or based on symptoms?
It depends. For lower-risk outpatients, a fixed-dose taper might work. But for inpatients, especially those at risk of severe withdrawal, symptom-triggered protocols using scales like the CIWA-R are commonplace. You give meds based on how severe the symptoms are at that moment.
And just to clarify, for alcohol-related seizures, it's benzos, not phenytoin.
Correct. Phenytoin, an anti-seizure med used for other things, does not work well for alcohol withdrawal seizures.
Yeah.
Benzos are the way to go. And other things like phenothiazines aren't as good at preventing complications either.
Okay, so withdrawal is managed. Then comes the really tough part, preventing relapse. What helps?
Well, self-help groups like Alcoholics Anonymous, AA, are definitely associated with better outcomes. Active referral helps. Other psychosocial support is key. Individual counseling, group therapy, CBT, sometimes residential programs, even just regular check-ins with a primary care doctor where they assess drinking and give feedback has been shown to help reduce use and potentially mortality.
And medications can play a role here too, as an add-on.
Yes, exactly. Pharmacotherapy is typically an adjunct to psychosocial treatment, helping to modestly improve drinking patterns or prevent relapse.
What are the main options for AUD medication?
Okay, first there's disulfiram, brand name Antabuse. It works by blocking alcohol metabolism. If you drink on it, you get really sick, nausea, vomiting, flushing.
A real deterrent then?
Pretty much. The evidence is a bit mixed, but it can be useful, especially if someone takes it under supervision. But there is a risk of liver injury.
Okay, what else?
Naltrexone, sold as Revia, or the long-acting injection Vivitrol. It's an opioid antagonist, but for alcohol, it seemed to work by reducing the rewarding effects, the buzz.
Interesting. Is it effective?
Yes, it's FDA approved, effective, and generally safe. A big plus is you can start it while someone is still drinking. The main caution is you can't use it if someone is taking opioids.
And a third option?
Acamprosate, or Camperol. It seems to work on brain chemistry, kind of stabilizing things after stopping alcohol, reducing cravings. It's also FDA approved and aims to support continued abstinence after detox. Diarrhea is a common side effect.
Any others sometimes used, maybe off-label?
Yeah, Topamax has shown some promise in studies for reducing drinking, but it's not FDA approved for AUD and can have significant side effects. Gabapentin also has some positive studies, but again, not FDA approved for AUD and carries some potential for misuse itself.
This is incredibly helpful for understanding alcohol. Now let's pivot to prescription drug use disorders, PDUDs, a very different but equally serious issue. First, what's the difference between just non-medical use and an actual use disorder?
That's a really key distinction. Non-medical use is basically using a prescription drug in any way other than how a doctor directed. So, taking someone else's pill, taking more than prescribed, using it just to get high.
Okay. And a prescription drug use disorder.
That's when the use pattern meets those formal DSM-5 criteria we talked about for SUD-impaired control, social problems, risky use, maybe tolerance or withdrawal. It signifies a more serious compulsive pattern.
How common is this non-medical use?
It's pretty widespread. 2022 data suggests about 14.2 million Americans, that's 5% of people 12 and older, use prescription meds non-medically in the past year.
And what types of drugs are most common?
Pain relievers, opioids are number one. Then tranquilizers or sedatives like benzodiazepines, and then stimulants.
The opioid crisis obviously looms large here. How did that develop?
Well, the huge increase in opioid prescribing back in the 90s and early 2000s directly fueled the crisis, leading to more non-medical use, addiction, and overdose death. Prescribing has leveled off a bit since then.
But the problem hasn't gone away.
No, because now illicit fentanyl, which is incredibly potent, has flooded the market and is driving a lot of the current overdose deaths, sometimes mixed into other drugs without people even knowing.
Where do people actually get these misused prescription pain pills? You'd think maybe mostly illicit sources?
Actually, no, and this is often surprising. The 2022 data shows the biggest source, about 45%, is getting them from a friend or relative, either given freely, bought, or taken.
Wow. Not primarily dealers then.
No. And another 41% got them through a prescription, maybe from one doctor, or sometimes by stealing from a provider. So the vast majority comes from social circles or legitimate medical channels initially.
That's really eye-opening. What makes someone more likely to overdose on prescription opioids?
Several key risk factors. A history of any substance use disorder is one. Taking higher prescribed doses, using them concurrently with other sedatives like benzodiazepines or with alcohol, that combination is particularly dangerous.
Anything else?
Yes, being prescribed long-acting opioids, especially methadone outside of a treatment program context. And critically, having had a prior overdose significantly increases risk for another one.
Let's look at that case. Miss S67, chronic pain, overdosed. She was on extended release oxycodone, hydrocodone, and lorazepam.
Yeah, her case tragically highlights those risks: higher dose, multiple opioids, and crucially, the concurrent use of a benzodiazepine sedative, lorazepam. That's a recipe for disaster.
Okay, let's dig into specific meds. Opioid painkillers first. You mentioned physiological dependence tolerance. Withdrawal is expected with chronic use, even as prescribed. How is that different from an opioid use disorder?
Super important point. Physiological dependence is just the body adapting. You'll get withdrawal if you stop suddenly. That's pharmacologic. An opioid use disorder, OUD, involves the behaviors, the impaired control, the social problems, the risky use on top of or alongside, tolerance, and withdrawal.
So not everyone on long-term opioids has OUD.
Definitely not. Estimates vary, but maybe somewhere between 3% and 20% of chronic pain patients on opioids develop OUD. The majority don't, even if they are physically dependent.
What about prescription stimulants, like Adderall or Ritalin? Why are they used non-medically?
Usually for concentration, staying awake, sometimes for euphoria.
What are the effects?
Acutely. High blood pressure, fast heart rate, fast breathing, loss of appetite, insomnia. Withdrawal often involves fatigue, depression, sleep problems.
Any other risks?
Oh yeah. Agitation, paranoia, hostility. Medically, you can see hyperthermia, heart rhythm problems, even seizures.
So being excessively sleepy wouldn't be an effect, right?
No, quite the opposite.
Yeah.
Stimulants cause alertness, insomnia is common. Extreme sleepiness might happen during withdrawal, though.
And sedative hypnotics, benzos like Xanax or Valium, sleep aids like Ambien.
These are definitely reinforcing. People can get hooked. They also cause physiological dependence. Big danger is their additive effect with other depressants, alcohol, opioids. Very risky mix.
What else do they do?
Impair memory, thinking, coordination. And interestingly, most people admitted for treatment for benzo misuse are also misusing alcohol or opioids. They often go together.
Are there other prescription drugs misused we should briefly mention?
Yeah, quite a few. Ketamine, some muscle relaxers like carisoprodol, gabapentinoids, even some antipsychotics like quetiapine, bupropion, anabolic steroids. But really, opioids and benzos are the main focus from a public health perspective due to the overdose risks.
Okay, so knowing all this, how do we tackle prevention and address PDODs?
We need strategies for different groups. People not taking controlled substances, people taking them appropriately for medical reasons, and people who are already misusing them or have a PDD.
Let's start with primary prevention, avoiding exposure.
Right. The most basic step is just don't prescribe these powerful meds unless absolutely necessary. Think about alternatives first.
Like using ibuprofen instead of oxycodone for some types of pain.
Exactly. Studies show ibuprofen can be more effective for certain types of acute pain. And for chronic pain, opioids often have pretty modest benefits long-term and can even lead to opioid-induced hyperalgesia, where the opioids make pain sensitivity worse.
Wow, that's counterintuitive. Okay, what about secondary prevention when prescribing is necessary?
That's where clinical guidelines are crucial, like the CDC's 2022 opioid guidelines.
What do they emphasize?
Prefer non-opioids first. If using opioids, use the lowest effective dose. Start with immediate release, not long-acting. Reevaluate benefit versus harm quickly within 1-4 weeks. If risks outweigh benefits, taper gradually. Don't stop abruptly. Offer naloxone for overdose reversal.
Naloxone, even for prescribed patients.
Yes, especially if they have risk factors.
Yeah.
Also, check the State Prescription Drug Monitoring Program, the PDMP, and be extremely cautious mixing opioids and benzodiazepines.
How do clinicians monitor patients on these meds? Urine tests.
Urine drug testing, or UDT, is one tool. It can confirm they're taking the prescribed drug and check for non-prescribed ones. There are screening tests, EIA, and more specific confirmation tests, GCMS.
Are there issues like false positives?
Yes, definitely. Poppy seeds can trigger a positive for opiates, some antidepressants for amphetamines. It's important to discuss results openly and non-judgmentally. It's about safety, not catching someone.
What about pain contracts or patient agreements?
They outline goals, expectations, risks. Guidelines recommend them, though the evidence they directly reduce risk is a bit mixed. They mainly help set clear boundaries.
And the PDMPs, the state databases, how useful are they?
They help spot potential doctor shopping, but they have limits. Not everyone uses them. People can cross state lines. They depend on timely pharmacy reporting. And remember, most misuse starts with drugs from friends' family, so PDMPs only catch a fraction of the issue.
So what if a patient shows aberrant drug-related behaviors, like asking for early refills, losing prescriptions, maybe getting pills from multiple doctors, like in that example?
The response needs to fit the behavior. If it's a misunderstanding, like the multiple doctors, education is key. Plus, setting clear expectations. I will be your only prescriber for these. If pain seems undertreated, maybe the treatment plan needs adjusting.
But what about more serious things, like selling pills or overdosing?
Then discontinuation might be necessary for safety. Other strategies for concerning behavior might include closer monitoring, more frequent visits, pill counts, UDTs, smaller prescription quantities, or referral to a pain specialist.
And if a prescription drug use disorder is actually diagnosed, what's the obligation then?
The clinical and ethical duty is to offer or refer for SCD treatment, even if the opioid prescription for pain is being stopped. A supportive, non-judgmental approach is vital. We have to treat the addiction itself.
This really shifts us to a broader view of substance use disorders generally. You mentioned seeing SCDs as a chronic illness, like diabetes. That's a huge reframing.
It absolutely is, and it's fundamental. SCDs aren't acute problems you just fix and they go away. They're complex, chronic conditions resulting from genetics, physiology, environment, behavior. Like diabetes, optimal management usually involves ongoing care, often combining psychosocial support and medication over the long term.
So short-term fixes like just detox aren't usually enough.
Rarely. Relapse rates after detox alone are incredibly high. It needs to be part of a longer-term strategy.
What kinds of psychosocial treatments are common?
Self-help or mutual help groups are Big NA, Narcotics Anonymous, Smart Recovery, the professional counseling, individual or group. Cognitive behavioral therapy, CBT, is well established. And even brief counseling, like we discussed for alcohol, can make a modest difference for illicit drug use, too.
We're also hearing more about harm reduction. What does that mean in practice?
Harm reduction accepts that not everyone is ready or able to stop using immediately, so the focus shifts to reducing the negative consequences.
Like preventing overdoses.
Exactly. Advising people not to use alone, making naloxone widely available, safe consumption sites where people can use under supervision. Also reducing infections through clean needle exchange programs. It's about keeping people alive and safer.
So the goals of treatment are broadening beyond just abstinence.
Very much so. Recovery today is seen more holistically. It includes things like better relationships, education, employment, improved quality of life things that the patient values. And critically, a return to use or relapse isn't seen as failure, but as part of the chronic illness process, something to learn from.
That sounds much more realistic and humane. How do you help someone who isn't even thinking about changing yet? Denial must be common.
It is. That's where motivational interviewing, or MI, comes in. It's a specific counseling style, collaborative, non-confrontational. It respects the people who are in different stages of change.
Stages of change.
Like pre-contemplation, not thinking about it. Contemplation, thinking maybe. Preparation, getting ready. Action, doing it. Maintenance, keeping it going. And potentially return to use. MI helps people move along that path at their own pace.
Are there specific techniques in MI? I think I heard the acronym FRAMES.
Yes, FRAMES sums up key elements. Give feedback on risks, emphasize personal responsibility, give clear advice, offer a menu of options, show empathy, build self-efficacy, confidence. It's also about eliciting change talk from the patient themselves.
What is change talk?
It's getting the person to voice their own desire, ability, reasons, and need to change. And eventually, their commitment. That's the darn C part. Hearing themselves say it is powerful.
How do you handle outright denial? It must be tempting to argue.
Arguing almost never works. Denial often comes from shame, feeling overwhelmed, maybe remembering only the good parts of use, or even drug effects on memory. The key is expressing genuine concern, showing empathy, offering hope. Gently restate facts, show you care, and look for openings.
Okay, let's focus specifically on opioid use disorder, OUD. We know opioids mimic endorphins, cause euphoria, but also dangerously suppress breathing. And fentanyl's dominance now makes things even riskier.
Absolutely. Illicit fentanyl is incredibly potent and often mixed into heroin, counterfeit pills, even cocaine or meth, sometimes without the user knowing.
The biggest acute risk is overdose, right? Treatment is naloxone.
Yes, naloxone Narcan is the antidote for injection nasal spray. But fentanyl is so strong, multiple doses are often needed to reverse an overdose.
What makes an overdose more likely?
Using other depressants like alcohol or benzos is a big one. Using stimulants concurrently can also mask opioid effects, leading to taking too much. And as we mentioned, reduced tolerance after a period of abstinence leaving jail, finishing detox is a huge risk factor for fatal overdose upon relapse.
Like that 56-year-old man who overdosed after a year clean. Tolerance was gone.
Exactly. It makes that first use after abstinence incredibly dangerous.
How do we prevent these deaths?
Effective treatment is number one. Medications for opioid use disorder, MOUD, dramatically cut overdose risk. Widespread naloxone availability and education are crucial. Supervised consumption sites also save lives.
Okay, MOUD. Medications like methadone and buprenorphine, these are considered first line.
Yes, definitely. Much more effective than detox alone for keeping people alive and in recovery.
Let's talk about methadone. How does it work?
It's a full opioid agonist. Satisfies cravings, prevents withdrawal, blocks the effects of other opioids. But it's highly regulated in the U.S., usually requires daily visits to a licensed clinic, especially early on. Higher doses, 80-100 milligrams, tend to be more effective. The structure can be a barrier for some.
And buprenorphine, often combined with naloxone as Suboxone.
Right. Buprenorphine is a partial opioid agonist. It activates receptors enough to prevent withdrawal and reduce cravings, but has a ceiling effect, making overdose on it alone less likely than with full agonists.
And the big change is that regular doctors can prescribe it now.
Huge change. Since 2023, any prescriber with a DEA license can prescribe it. The Special X waiver is gone. This makes it much more accessible, available in primary care offices. Doses of 16 milligrams or more daily are usually needed.
What's the catch with starting buprenorphine? Precipitated withdrawal.
That's the main thing to watch. Because it's a partial agonist with high affinity, if you take it when you still have a full agonist like heroin or fentanyl active in your system, it can knock the full agonist off the receptors and trigger sudden, severe withdrawal. You have to wait until someone is in moderate withdrawal before the first dose.
Okay. What about extended-release naltrexone, Vivitrol?
That's an antagonist. It blocks opioid receptors. It's a monthly injection. The challenge is you have to be completely opioid-free for 7-10 days before the first shot. That waiting period is a major hurdle for many people.
There's still this stigma, though, that MOD is just replacing one drug with another. How do you counter that?
It's a harmful misconception. MOD medications stabilize brain chemistry disrupted by addiction. They don't typically produce euphoria at therapeutic doses. They allow people to stop the cycle of intoxication and withdrawal, reduce cravings, prevent overdoses, and function. Normally, go to work, care for family, engage in therapy. It's life-saving medical treatment, often needed long-term, like insulin for diabetes. Stopping MODI often leads to relapse and increased mortality risk.
What about detox or medically supervised withdrawal on its own?
It's generally not recommended as the primary treatment for OUD because relapse rates afterward are so high, leading to that increased overdose risk due to lost tolerance. Opioid withdrawal feels awful, but isn't usually life-threatening like severe alcohol withdrawal can be.
What meds are used during detox to ease symptoms?
Buprenorphine can actually be used short-term for withdrawal management and is often the most effective. Methadone can also be tapered, or non-opioids like clonidine or lofexidine, which are alpha agonists that help with some autonomic symptoms. But detox must be followed by ongoing treatment or aftercare therapy, support groups, potentially starting MOD to have a real chance of success.
Okay, let's shift quickly to stimulant use disorder. Cocaine, meth, MDMA, bath salts.
Right. A different set of problems, but also very serious.
What are the main medical dangers?
Cardiovascular issues are probably the biggest concern. Heart attacks, aortic dissection, stroke, blood vessel problems. Cocaine can cause a heart attack even in people with normal arteries, any way they use it.
What else?
Rhabdomyolysis, muscle breakdown. Hyperthermia, dangerously high body temperature, especially in hot settings or with exertion. And infections like cellulitis or endocarditis for people who inject.
Is treatment effective? Are there medications like for OUD?
Unfortunately, pharmacotherapy for stimulant use disorder is much less established. Some drugs like bupropion, naltrexone, topiramate have shown some promise in some studies, but results are inconsistent. There's no FDA-approved gold standard medication yet.
So treatment relies more on psychosocial approaches.
Yes, self-help groups, counseling, CBT, brief interventions can help too. And one therapy that is highly effective, especially for stimulants, is contingency management.
What's that?
Basically providing tangible rewards like vouchers or small cash incentives for objective proof of abstinence like negative urine tests. It works really well by reinforcing positive behavior change.
Why isn't it used more if it's so effective?
Often logistical hurdles, funding issues, sometimes philosophical objections to paying people not to use drugs, even though the evidence shows it's very effective and often cost-effective.
Okay, last category. Cannabis and hallucinogens. Cannabis, marijuana is super common. THC is the main psychoactive part. And synthetics like Spice K2 are out there too.
Yep, and they can be much more potent and unpredictable.
What are the known medical issues with cannabis?
Well, neurocognitive impairment effects on thinking, memory, attention, especially with heavy use starting in adolescence. Some effects might persist. Increased risk of car accidents is clear. Respiratory symptoms like cough and wheeze are common with smoking, but it hasn't been definitively linked to causing COPD like tobacco has.
Anything else emerging?
Some recent data is suggesting a possible link between cannabis use and heart attack and stroke, but that's still being actively studied and understood.
And hallucinogens, LSD, psilocybin, mushrooms, PCP, ketamine, MDMA, big range of effects.
Huge range. They fundamentally alter perception, thought, emotion, can be intensely pleasurable or insightful or incredibly frightening a bad trip. Judgment can be severely impaired, leading to risky behavior.
PCP, or angel dust, seems particularly notorious.
It often causes dissociative symptoms, feeling disconnected from reality or yourself. Plus, slurred speech, unsteadiness, can lead to psychosis, paranoia, agitation, sometimes violence. Overdoses, dangerous seizures, coma, heart or breathing stopping.
And MDMA, ecstasy, or Molly.
It has stimulant-like effects, high blood pressure, hyperthermia, muscle breakdown, heart rhythm issues, can cause liver or kidney failure. The specific danger is severe hyponatremia, low sodium from drinking excessive water, combined with hormone effects, which can be fatal. And pills sold as ecstasy often contain other unknown dangerous substances.
What about LSD flashbacks? Are they real?
Yes, hallucinogen persisting perception disorder, HPPD, is real, though uncommon. People can re-experience visual distortions long after use. But generally, long-term neuropsychological problems from LSD seem relatively modest for most users.
Is there much treatment for cannabis or hallucinogen use disorders?
Evidence is more limited compared to alcohol or opioids. Counseling focusing on realistic health risks is important. For cannabis use disorder, counseling and CBT approaches have shown some success in helping people cut down or quit.
Wow. We have covered a ton of ground today. We've really gone through the whole landscape defining drinks, the changing view of healthy use, the shift to use disorder screening, withdrawal, treatment options for alcohol.
Then diving into prescription drug misuse, the opioid crisis monitoring strategies, MOU, stimulant issues, cannabis, hallucinogens. It's a lot.
It really is. But understanding these medical realities, it empowers you, the listener, to look at information critically, maybe recognize signs of problematic use in yourself or people you care about.
And hopefully appreciate the value of compassionate, evidence-based care, moving away from judgment.
Absolutely. So as we wrap up, here's a final thought. As our understanding of substance use disorders keeps evolving, shifting from seeing them as moral failures to complex chronic illnesses, what fundamental shifts in how society thinks and in our public health approaches do you think are most crucial to really support widespread recovery and well-being?
Something to definitely chew on.
Thank you for joining us on The Deep Dive.